Hello, everybody.
And
Welcome.
and Samantha, you're in Vancouver area, right?
No, I'm actually in Northern Ontario.
Oh, Northern Ontario. Okay.
Yeah,
Oh, and here we go. We're already going all different areas of Canada
yeah,
so far.
it's incredible.
Okay. Hello, everybody. Welcome to the Institute of Holistic Nutrition. And my name is Theodore. I'm one of the program managers and advisors here at IHN. And on behalf of IHN, I'm really excited to introduce today's speaker and topic. And we actually have a very unique and interesting array of people joining here today. We have other fellow practitioners in the industry. We have graduates of IHN. We have students of IHN. We have members of the public today. So it makes for a really exciting group. And so I just want to maybe give a little bit of an introduction at first, give you a bit of context for today. And so for those of you who are just getting to know us, we're really proud to share that IHN's now been around for 30 years, where we've been training people to become practice ready holistic nutrition practitioners in 12 to 24 months so that they're not just certified, but ready to work with real clients. But we also have our continuing education courses. And so our IHN graduates, they're fully equipped to practice in the industry as leading practitioners. And so our continuing education courses are something that we do to help support them even further. And educational courses, some of them take topics from within the courses in the program and go into more detail. And so today we're talking about topics, relating to pregnancy and fertility, PCOS. And so that primarily we're going to be looking at from the nutrition through the lifespan course in our program. And in that course, you're looking at how your nutritional needs vary from prenatal to your senior years, gender differences, allergies, hormones. And so, this pregnancy and early childhood course is for people that have already completed our program that are looking to specialize even further in that area. And we have some graduates that do some excellent work there, including Dr. Samantha Vanderwall. Now, she is a naturopathic doctor and a graduate of IHN, and she has a special interest in women's health and fertility. And in addition to her private practice, Dr. Samantha is a medical blog writer and a faculty member at IHN. So in the past, she taught that nutrition through the lifespan course that I mentioned. And now, very excited to have her teach our naturally designed pregnancy and early childhood course. So I'll pass it over to her now. She'll be able to give a bit more of an introduction about herself if she wants, but the topic, and then there will be some Q&A afterwards as well. So make sure to hold on to your questions there. We'll get to them at the end. And yeah, I guess take it away, Dr. Samantha.
Thank you so much, Theodore. I'm gonna go ahead and share my screen so we can get that PowerPoint up, and then I am gonna do an additional little introduction. Um, Okay, thank you so much again, Theodore, for the introduction. As he was saying, my name is Dr. Samantha Vandal. I'm a naturopathic doctor. And prior to completing my studies at the Canadian College of Naturopathic Medicine, I did complete my applied holistic nutrition diploma at IHN and practiced as a PCOS focused nutritionist. And it is such a pleasure to be bringing this information to you. Um, what I want to start off by saying that this topic, that PCOS is not one size fits all, comes from a place of immense understanding. Having been diagnosed with PCOS myself in 2017, I didn't necessarily fit the image of what I was taught was PCOS in my studies. And it confused me tremendously because what I knew about the condition was somebody had to be potentially overweight and eat, a lot of carbohydrates or not eat a healthy diet. And only through my own experience did I immerse myself in the material and come to understand that there are a variety of root causes to turn that PCOS switch on. And PCOS is certainly a topic that we're going to talk about within the context of fertility today. And then, of course, within the naturally designed pregnancy course, which I have the honor of teaching in March, beginning March 24th, which I have here. So, um, just like Theodore said, I'm also a former teacher. So I love that I'm able to bring that back into my work now as a practicing naturopath and a holistic nutritionist. And most importantly, I'm a mom. So having gotten that PCOS diagnosis in 2017, as we'll talk about, it can often scare a lot of people into, having fears around their fertility potential. And so it makes me very excited that I was able to apply everything that I came to learn and integrate it and, healthily, naturally conceive my daughter. So the goal of this webinar, by the end of it, you will learn the appropriate questions to ask your clients to help, understand if this is a true PCOS diagnosis. All of the root causes that I've put together, there are 6 different ones that we're going to talk about today. And it's not just about calories, it's not just about carbohydrates. The most important symptom to resolve for management and improve fertility, we are going to touch on interpreting labs. So we're going to look at blood work and dried urine, as well as stool analysis, and how that can come to build your treatment plans for your PCOS clients. We will look at the nutritional gaps that you can help your clients to fulfill through diet, of course, and through supplementation, and understand the best diet for your PCOS client as well. This is just a disclaimer that this presentation is for educational purposes only. It's not intended to give any medical advice, to diagnose, or to treat. And also that this information within the presentation today is only up to date to today. So if you are watching the replay in, months or years to come, it could be that the information changes as new information emerges. So, what is PCOS and why do we care? Especially, so if you're here, you probably have either a professional interest in fertility, women's health, and reproductive care, or perhaps you have a personal experience with it. Or you are potentially looking to expand your practice into a fertility or women's health niche. And PCOS, I remember when I was diagnosed in 2017, the first thing that I Googled was, what is PCOS? And the first thing that came up for me was the number one cause of infertility. Well, that can make a woman's heart break to think that this could be the loss of her fertility potential. But what we know about it is that it is so profoundly um, uh, the response to our natural interventions is wonderful. This is such a wonderful condition to treat with naturopathic and natural interventions, and responds beautifully to the medicine that we have to offer. There is an ongoing fertility crisis. Right now, we're at about 20% of the female population that are affected just with PCOS. We know that couples are experiencing fertility decline at a rate of 1 in 6. So 1 in 6 couples experience fertility issues. So these are large numbers. And if we can help in some capacity to support improving these statistics, we are not only impacting the health of our current generation, but we're also positively impacting the health of the babies and the generations to come. It is also a condition that cannot not be treated. We need to treat this condition because left untreated, there are long-term health implications from metabolic issues and cardiovascular issues, looking at, increased risk of metabolic syndrome, for example, or cardiovascular disease, and hormonal implications, as well as endometrial cancer, which we will talk about that mechanism too. So this is a condition that definitely needs to be treated. And of course, quality of life. There are a number of mental health disorders that are comorbid with the condition: anxiety, depression, sleep apnea. And by improving PCOS from a root cause, we can help to support the quality of life in these individuals as well. So if you're not familiar with PCOS, I'm going to go through the criteria of how an individual would get diagnosed, and that will shed light on the symptoms that often, females are experiencing with this condition. So, in order to be diagnosed, somebody needs to have irregular cycles. That is, cycles that are coming more than 35 days in length, or not cycling at all, less than 6 cycles per year, and or an ovulation. So, not ovulating. So, irregular cycles or lost menstrual cycles is a cardinal symptom of PCOS. The second one is hyperandrogenism. So, these can either be clinical signs, so observable in, for example, hair growth in unwanted areas. That could be on the face, around the nipples, below the belly button. It could also be hair loss. It could be acne on the face, on the back, um, and they could be either, like I said, visible, or they could be showing up via blood work. So we will talk about what hormones we're going to test to assess for that. But that's one of the criteria. And the last criteria is multiple cysts on the ovaries. And you can see there, I've mentioned greater than 12 follicles and the size as well. So in order to reach this criteria, you only need 2 out of 3. A lot of, my patients will come in and say, well, I haven't had an ultrasound. And just by virtue of them having irregular cycles and signs of high androgens, I can make that diagnosis for them. Now, even if you cannot formally make a diagnosis, this criteria is really important for you as a nutritionist, because if they come in with the first 2 patterns, you have a pretty good idea of what you're dealing with. The exception is, I guess we'll go back to, oh, the exception is some of the differentials, which I'll go back to in just a second. Okay. Um, so the hallmark features are the lack of ovulation, irregular cycles, the high androgens, hair loss, hair growth in unwanted areas, acne, and the polycystic ovaries. But underneath that iceberg, we're really dealing with a tremendous amount of metabolic disturbance, including hyperinsulinemia, so elevated insulin, insulin resistance and glucose intolerance, dyslipidemia, which could often show up as high cholesterol, and inflammation. Today, we're really going to uncover, how these manifest. I thought I would start off with this slide that includes questions to include in your intake. It doesn't necessarily have to be in a form, but it could be conversations that you're having in your client visit. So, of course, the menstrual cycle history is really important. I'm not going to read through all of this verbatim, but I'm going to highlight a couple of things that I think are especially important. So, less than 25-day cycles are really important, even if they're coming regularly, because we are at that point going to suspect that that female is not actually ovulating. So they could still be having a regular cycle at the 25-day mark, but we know that there's probably an ovulation issue, because the only way that we have that cycle to be maintained greater than 25 days is when we have enough of the hormone progesterone only produced through ovulation. So you might see some heavier bleeding here. I always want to know about the history of hormonal contraceptive use. The question that I ask is, were you placed on hormonal contraceptives for the purpose of contraception, or was this to regulate cycles or for another reason? And that can give you some insight into how long they've been dealing with this concern. If they are tracking their cycle, so confirmation of ovulation through LH strips, and I absolutely love basal body temperature, because it can tell us exactly how long they're getting that hormone surge for, and if there are any issues with like issues with the luteal phase. So if that luteal phase is not quite long enough, that's something we can target. Um, any sort of skin health symptoms we can relate back to it being a result of androgens or insulin resistance, which we will talk about. So the hyperkeratosis, or some people know this as keratosis pilaris, even the chicken skin on the back of the arms is a sign of insulin resistance. Having that alone is not a diagnostic marker for PCOS, but that can help to paint that picture of, is this an insulin resistant picture? Acanthosis nigricans is skin thickening, particularly in armpits or in creases. And once we understand what the root cause is around that, we can help these patients to resolve that symptom if they're feeling like they don't want that symptom anymore. I gave you a tool to use in practice, the Framingham assessment, to monitor hirsutism, because it's a tricky one sometimes to monitor. Hirsutism is that hair growth in unwanted areas. There's some tools there for mood disruptions to understand how their moods are evolving and responding to your treatment plan. So the GAD-7 and the PHQ-9 are very accessible on mdcalc.com. We want to know about their current nutritional intake. So, I will always relate this back to my story with PCOS, which was I was not eating enough calories. I was eating a lot of salads. I was drinking a lot of coffee, and my nutritional intake was not enough. So, PCOS is not just based on excess calories and being overweight. It can be caloric insufficiency, and you can still have insulin resistance as a result of that. Um, Understand weight. Is it stable? Is there weight loss resistance, or are they lean? That is going to help guide your nutritional recommendations as well. Because if you are, suggesting somebody, we'll talk about that in a second. I'm going to get ahead of myself. Um, Gut health is really important, as we will come to understand that as a root cause of PCOS. If they're bloated, if they're constipated, if their bowel habits are irregular, we might be curious about, is this an irritable bowel scenario? What are the root causes around irritable bowel? That is going to contribute to how we decide to treat this. Um, Stress and how that influences the HPA axis, and as well as their lifestyle, which we'll talk about as well, but that's on there for you to reference. I'm not going to go through these ad nauseum, but it's really important that you know that there are other diagnoses that resemble PCOS, and particularly Cushing syndrome and non-classical adrenal hyperplasia. So that would be this first one here and this third one here. It can absolutely resemble a PCOS picture. In this case here, we're looking at screening through a 24-hour cortisol test, as well as a dexamethasone suppression test. These are not items that you would have access to, but it could certainly be a next step for clients where maybe you're not sure if this is PCOS and you want to make sure that you rule that out before pursuing treatment. Same thing with non-classical adrenal hyperplasia. It absolutely mirrors PCOS symptoms. So you can get a naturopathic doctor in Ontario, at least, or if you're working with another functional medicine provider who has access to serum testing to rule that out prior to deciding to treat if you're unsure of the diagnosis. But I think this is an important slide just to have in your clinical pocketbook. 6 root causes of PCOS. So like I said, it's not just based on carbohydrate intake, and excess calories. There are 6 things that could potentially be going on. And in some cases, you might see really all 6 of them at play. So let's dive into these. The first one is, of course, insulin resistance. By far the most common. Upwards of 80% of females are going to have underlying insulin resistance. So, like I mentioned earlier, they could still be of a lean body type or not necessarily overweight. I want to acknowledge that I am going to mention BMI in the presentation, because this is a starting point, especially if you don't have, like, if you're working virtually with patients, we don't often have the physical inspections that we want to have with those patients. So BMI is a jumping off point to see if they are within that normal weight range. Waist circumference for females, so greater than 80 centimeters, is associated with insulin resistance, and actually is our best tool. So they could do self measurements at home if you're doing a virtual appointment, or of course you could do it for them. But that is our best tool to measure insulin resistance, apart from blood work, let's say. So it's the best physical exam for that. Other signs would be weight gain along the midsection, the greater than 8 waist to hip ratio, and then the skin changes. So the acne, skin tags, acanthosis nigricans, and the hyperkeratinization. We will talk a little bit about blood work. HOMA IR is when we take fasting insulin and fasting glucose, and we get a ratio. Less than 2 is ideal. And the triglycerides to HDL ratio, if you have access to their blood work, we want to see one that's less than 1. And we'll talk about the insulin glucose challenge test. This is by far the number one thing that plagues females with PCOS, and we're going to see how those other root causes can even worsen insulin resistance, which I think is important because it's not just diet or lack of exercise. The second one is chronic inflammation. We will talk about how the gut drives inflammation, which then drives insulin resistance. Adipose tissue alone is a major inflammatory source. So there are cases where weight loss on its own can help resolve some of the symptoms that people are experiencing, particularly ovulation. And we will talk further to that as well. Oxidative stress and inflammation often occur together. And we might see this in cases of elevated CRP. There are also oxidative stress markers on a dried urine test. And oftentimes with PCOS, there is elevated CRP. CRP is a broad spectrum inflammatory marker. It can tell us about if there is a link between their cardiometabolic health and inflammation. When we pair a cholesterol panel with a CRP, that tells us if it's more specifically cardiometabolic function. If the cholesterol panel looks good, we might point to more of a general inflammatory picture, potentially related to gut health or like a standard American diet, which is higher, as we know from all of our studies here at IHN, to be higher in omega-6s relative to omega-3s. This third one is the gut microbiome. And I'm very passionate about this topic because I would say about 10 years ago, this was not acknowledged by people to have influence on PCOS. But as it stands, my first issue and reason why I got into natural medicine was not PCOS. It was actually because I went away to teach and went away to Ecuador to teach, and I got very sick while I was there. Came back and, of course, got diagnosed with IBS. Fast forward 10 years, of course, I find out that I have H. pylori, a gut microbiome disturbance, and that absolutely was driving inflammation, which was driving insulin resistance in my body. So I'm very passionate about this topic. And I think as nutritionists, we're so well positioned to target this because we have a grand understanding of the 4 or 5R protocol, whichever one you're putting into place. But here's what we know so far. So the dysbiosis, meaning the imbalance of beneficial to harmful bacteria, can create low-grade inflammation. And then this can create intestinal permeability, leaky gut, and then we get the metabolic endotoxemia, which is the lipopolysaccharides. These are protective mechanisms of these microbial species entering into our bloodstream and driving inflammation, driving insulin resistance. That's part one of how the gut microbiome is going to influence insulin resistance and therefore, signal to turn on PCOS in genetically susceptible individuals. Part two, what we see is that there is a lower gut microbial diversity in females with PCOS than control groups. So this means that there are less of the beneficial species, lactobacilla, bifidobacteria. Those two specifically are involved in hormone metabolism. So really important because that's the way that our hormones get out of our system is through our GI tract. And they're also involved in nutrient absorption. So there are those key nutrients that are low in individuals with PCOS. And then Akkermansia and the Ruminococcosia involved in gut barrier integrity and anti-inflammation. Specifically, these are going to help produce a little bit more mucus in the gut to protect the gut lining from eventually becoming permeable. So those species are lower, meaning, females with PCOS are at risk for having leakier guts. Therefore, allowing those toxins to seep into the bloodstream. We see that there are, specific strains that show up in females with PCOS that can lead to what I'm talking about. And the high fat or high carbohydrate diets can also lead to gut barrier disruption, which is going to inevitably lead to insulin resistance as well. Metabolites produced by fiber, so generated by bacteria. This is relevant because there are studies that show females with PCOS tend to consume less fiber than their controlled counterparts. Fiber is food for bacteria, for the beneficial bacteria in your gut, and they help to proliferate those beneficial bacteria, and they produce short chain fatty acids. Short chain fatty acids prevent obesity. And we can see here, they go on to activate these G protein coupled receptors, which release GLP-1 and peptide YY. Obviously, GLP-1 getting a lot of attention right now, especially within the realm of type 2 diabetes, insulin resistance, and PCOS. And this is partly the mechanism. This is an amazing visual that is showing you exactly what we just talked about. So how the gut dysbiosis increases, that inevitably goes into systemic inflammation, which triggers systemic inflammation, and then that triggers hyperinsulinemia. So driving elevated insulin. Insulin will increase testosterone at the level of the ovary. When there's an increase in testosterone, there is less estrogen, and that shuts off ovulation. So there absolutely is a connection between what is going on in the gut and ovulation regularity, cycle regulation in females with PCOS. I love this visual so much. So nutrient deficiencies, we just talked about fiber. Oh, I have a typo here. This is supposed to be macronutrients. Fiber as a nutritional deficiency in females with PCOS. Protein also, studies are showing that females with PCOS are not getting enough protein. And that's such an easy fix to help your clients with. I always give the analogy that we can imagine protein as a brick house, and it is made up of these tiny bricks, which are amino acids. And amino acids go on to perform things like, we think of them, of course, for muscle building, which is helpful for insulin resistance, but they're going to go on to create neurotransmitters for better mood regulation. They're important for liver detoxification. They're important for hormone production and signaling. So it's so much more than just muscle building, which is why we really want to get it to sufficiency. I'll touch on it here. Generally, I'm looking at 1 gram of protein per pound of body weight per pound of ideal body weight for my patients. And then the micronutrients, so vitamin D, magnesium, chromium, all three of those, when low, are related to insulin resistance. So deficiencies in those will drive insulin resistance. Um, B vitamins are important because we see, especially vitamin B9 and then B12, folate and methylcobalamin, they're often low in individuals with PCOS as well. Zinc is important for hormone signaling to modulate testosterone. In cases of low, it can make it high. In cases of high, it can make it low, but that's really important. And omega-3 fatty acids to help with that ratio of omega-6 to omega-3, especially if they're coming from a standard American diet. And inositol. Inositol is actually a naturally occurring substance in the body. It acts like a B vitamin. And in individuals with PCOS, they have less production of inositol. Inositol is a natural insulin sensitizer. So if females with PCOS are not producing enough of it, they then have more insulin resistance. So inositol is an excellent tool to help improve insulin resistance, which we will also talk about when we highlight some supplements. It should be no surprise that HPA axis dysregulation is also going to drive PCOS symptoms. And the key word here is via gluconeogenesis. I always tell my patients, if you're stressed and you're skipping meals because you're stressed, well, your body's going to make its own glucose. So it can actually become insulin resistant, if there's just chronic stress, but you're fasting. So stress really is so important to be regulated. Um, so looking at stress management, of course, but then also looking at sleep patterns. Poor sleep and disrupted sleep, so things like eating before bedtime, which can disrupt sleep, or not sleeping on a regular circadian rhythm, so sleeping around the same time and waking up at the same time every night, this can lead to metabolic dysfunction. A poor night's sleep, and maybe you experience this, can lead to more cravings for carbohydrates, and you are more insulin resistant and leptin resistant when you have poor sleep. The genes is an important one to mention because a lot of people might think I caused this, right? Like I caused my PCOS, when in fact, that's not necessarily true. There's about a 70% susceptibility, which is quite high. And we are dealing with so many environmental, like external environmental exposures that are going to turn these genes on. We know there's a connection to PCOS and bisphenol A, so BPA, also phthalates. Really important that we are doing the things that nutrition and the environment taught us. So, drinking out of stainless steel and glass bottles, replacing all of our plastic, looking at our personal care products. So, using tools like the Environmental Working Group, Skin Deep database, or Think Dirty. There's a few of them on the market now. That's really important so that we can, empty our barrel, so to speak, as much as possible. Um, and when I, earlier was speaking to the health of future generations, right? We know that these chemicals can accumulate. Fortunately, when we start to take them out, they get out of the system fairly quickly. But we want to be able to conceive healthy children that are not starting with their bucket already half full as well. So that's really important. Okay, some lab interpretation. So, this is the blood work that I would typically order for a PCOS patient. Of course, looking at their complete blood count, which can tell us just about their general health, inflammatory state, and some nutrient deficiencies, and their vitamins as well, B12 and D, which are often deficient and easily correctable. I like to test vitamin C when there's been long-term chronic stress or you suspect HPA access dysfunction, because we know vitamin C is a nutrient that is really used up by the adrenal glands. So that can help when if somebody's been in a state of chronic stress for a significant amount of time. Red blood cell magnesium, as opposed to serum, has better accuracy. So it's a little bit pricier, but it tells us more about their magnesium status. Magnesium is so important for insulin resistance and also the absorption of vitamin D, if we recall, and folate as well. You've got those inflammatory markers there, and you'll see ferritin twice. Ferritin is a storage form of iron, but when it's high, it's an acute phase reactant. It tells us that there is inflammation in the body, and so we can target that appropriately. Urate is an interesting one, which is not often talked about, but that can tell us a little bit about if there are gut bugs. So serum urate tells us a little bit about that. Um, and then metabolism, we've talked about cholesterol, triglycerides. I'm going to talk about the insulin glucose challenge test on the next slide. And then hormones. So if they're cycling, we need to see LH, FSH at a ratio of 1 to 1. Estradiol, which is often low because you have the testosterone hoarding all of that estrogen. And then we have the progesterone. So if they're cycling regularly, get them to take their basal body temperature and do the LH strips, and we can test progesterone 7 days after ovulation to see how much progesterone are they secreting. And that tells us a little bit about egg quality and if we need to do some work there. Testosterone and DH, testosterone always, but DHT, if there's significant hair loss, sex hormone binding globulin can tell us if testosterone is high because of insufficient sex hormone binding globulin. Insulin resistance lowers SHBG. We've got some HPA access markers there as well. Cortisol, TSH, and thyroid antibodies are important. As part of your differential diagnosis slide, I put hypothyroidism. The number one cause of hypothyroidism is often Hashimoto's. The thyroid and progesterone, they have this really interesting relationship whereby once ovulation happens, progesterone can signal to the thyroid to increase its metabolic rate. And that's why we see a rise in that second half temperature of a cycle. But also with poor thyroid function, we don't get appropriate progesterone surge. Ovulation is impaired, and that can often be comorbid. They can come together. The Hashimoto's and PCOS, they're often seen together. So that's why we like to rule out those thyroid antibodies. I want to highlight the insulin glucose challenge test. So naturopathic doctors can run this test. So if you're working with a naturopath or functional medicine practitioner, this would be a really great way to offer, your services or to get access to it and interpret it for your own clinical findings. Because what this tells us is not just what their insulin is at the fasting mark. Like you can see here. So these are two different patients. The second one here, this individual has an elevated BMI, and her insulin fasting is good. We typically like to see this below 50, ideally below 40. So on its own, it looks fine. But oh no, sorry, these should be switched. I'm so sorry. This is the lean and this is the elevated. So lean on its own, it looks fine. But at the 0.5 hour mark, it's actually increasing quite a bit. So it's surging to 330. That's quite a differential. So still demonstrating insulin resistance, even though they're of a normal BMI. Okay. And this is why it's really important. What we want to see with the insulin glucose challenge test is a slight rise after fasting, and then we want it to come down again. So that is what has happened, but this stark rise is suggestive of early insulin resistance, which is for sure contributing to some of those symptoms that she was having, which was irregular cycles, hair growth in unwanted areas. Um, the elevated BMI, the insulin fasting on its own is quite high. So it's still over the 50 that we want to see it at, the 50 picomoles per liter. Then you can see the stark rise to 1,061 picomoles per liter. So that jump is very significant. This is a more severe case of insulin resistance. So you're going to treat these potentially, differently because this normal or lean PCOS, you're probably not going to need to do caloric restriction. You probably want to do a little bit of insulin sensitizing, carb modification. But with a more severe insulin resistance case where the patient has an elevated BMI, they're kind of stuck at a weight loss plateau, this is when we want to manage the macronutrients a little bit better, get into a little bit of a caloric restriction. So this is why I love the insulin glucose challenge test, because it really offers up nuance and customization to the patient's nutritional plan, as opposed to just exercise more, eat less. Okay, so that was blood work. As a holistic nutritionist, like when I was practicing as a nutritionist prior to becoming an ND, I did more Dutch testing because that's what I had access to. And the Dutch test can provide a lot of wonderful information when it comes to hormones, HPA access. Where the downside is it doesn't get the cardiometabolic hormones that we looked at. Like it's not going to do the insulin glucose challenge test. It's not going to, rule out some of those cardiovascular risk factors, lipids panel, for example, CRP, ESR. But it's a great starting point to understand how the hormones are, how they're operating, and you can make assumptions about, based on their history, about how their lifestyle could be implicating their hormones that are showing up on a Dutch. It's also a really great option if, patients, if you're feeling stuck in a care plan, maybe you've looked at the blood work and you're still feeling a little bit stuck. So a couple things that I want to highlight about the Dutch. So it can tell you about the androgen activity. Oftentimes, there is a preference for androgens to get metabolized into the 5 alpha reductase pathway when there's PCOS. And this can show up as the hair growth in unwanted areas or acne for people. And it's an important differentiator because acne can be caused by androgens, it can be caused by insulin, it could be caused by estrogens, but you're going to treat them differently, right? So if it is because of androgens and androgens alone, I've left some clinical pearls there in terms of some herbs and nutrients that can be helpful to down regulate that pathway. Another key highlight from the Dutch that's useful is the estrogen and the metabolites. What we don't know in so many PCOS patients, if we don't run their day three hormones, is their estrogen high or low? For many of them, it's in a low state, but for some of them, it is in a high state. And the Dutch does a really great job at telling us, is it high? Is it low? And I've left a clinical pearl there for if it's low, here's how you increase it. If it's high, here's how you help with metabolism. And then, of course, what's beautiful about the Dutch is, again, if you have that patient who you think it's more of a stress picture, you want to see what's going on with their cortisol throughout the day, it can paint that picture for you as well. Gut microbiome testing, I'm a big fan of gut microbiome testing when there are issues with the gut. Of course, you can always have a client who has PCOS and their gut is fine. And maybe you might opt for like a broad spectrum probiotic or increasing fiber, which we'll talk about. But given what we know, for example, like here are low levels of akkermansia, so low mucus, which is protective for metabolic syndrome. Akkermansia is protective for it. So we want to raise that akkermansia. This is trending, the lactobacillus is trending low in this case, so we can support lactobacillus species. Here are some opportunistic bacteria that are elevated. Of course, long-term can lead to endotoxemia. And then here we're looking at zonulin being elevated, which is the marker of intestinal permeability. Zonulin, of course, is the band-aid to leaky gut. So it is going to give us a lot more guidance with our clinical decision making. But the 5R or the 4R gut framework, remove, replace, repair, reinoculate, and rebalance, is an amazing place to start if you suspect that there is a gut microbiome imbalance. I'm going to just sneak by that. In an effort to preserve some time. So the number one thing that we need to resolve for PCOS is ovulation. Regular ovulation is the only way that we're going to get that true hormonal balance between estrogen and progesterone. And a couple things that work right off the hop. If that patient or client is of a higher elevated BMI, if they have a higher waist circumference, a 5 to 10% reduction in body weight will restore ovulation in 50% of overweight women with PCOS. That's pretty significant. It is a clinically significant finding. I would just caution, we're not doing this with like 1,200 calories in MyFitnessPal. We're doing this really sustainably, and we're doing it with whole foods. And inositol, a favorite of mine in observational cohorts, inositol restores ovulation after 10 weeks. So they will start to feel reduction of cravings, better metabolic control in as little as I would say 2 weeks. But the cycle regularity might take 1 to 3 cycles of being on inositol. Other ways that we can restore ovulation are N-acetylcysteine, a high potency precursor to glutathione, our body's master antioxidant. So if you suspect particularly high levels of oxidative stress or inflammation, this is great for that. Poor egg quality, it's great for that as well. And it's also a great insulin sensitizer. Vitamin D, omega-3s, and high fiber, which we're going to talk about. I'm going to leave this here as is. So these are the evidence-based supplements for PCOS. These are what I call like the foundational supplements for PCOS that are going to support insulin sensitization, reduction of inflammation, and key nutrient deficiencies. But this sentence here is the most important. So customize your supplements and your protocol based on the human being sitting in front of you. I'd like to see these six, if not all of, some of the six supplements that are here in a foundational PCOS protocol. But if that patient is experiencing chronic stress and HPA axis dysfunction, this is when our protocols for supporting adrenal fatigue and low adrenal levels work beautifully. The integration of, like I mentioned earlier, vitamin C, certain adaptogens, B5 specifically, magnesium at higher dosages. So really customizing it. And again, like if they have gut microbiome issues, you're going to go into the 4R protocol. You're not necessarily going to just do this, right? So these are really important for the broad symptoms of PCOS, and then tailoring it to those root causes is especially important. Herbs and polyphenols, there are a number of them that work tremendously at supporting insulin sensitization. Berberine works also on the gut microbiome. So if there's an overgrowth of gut bugs in the system, berberine is fabulous for this here. I usually do twice a day dosing with it, but you can do up to 3 days, up to 3 times per day, but short-term dosing because it is going to modify the gut microbiome. Cinnamon, curcumin, resveratrol, these are all amazing polyphenols that you could suggest that they add to their food, so food-based, or depending on what their main symptoms are, you might want to do in supplement form. Cinnamon's great for insulin, curcumin is great for inflammation, resveratrol is great for inflammation and oxidative stress. Milk thistle, if they have NAFLD, so non-alcoholic fatty liver disease, is really great for supporting the liver enzymes. Spearmint tea, we talked about the sex hormone binding globulin. We need that guy to help bind out testosterone out of the system. We know that spearmint tea can help to do that. It's a very simple, cost-effective way to do that. And then the licorice and white peony combination, you may have seen it on the Dutch test slide. That's going to help to convert testosterone into estrogen. So if estrogen is low and testosterone is high, this traditional Chinese medicine combination works really well. Okay, the best diet for PCOS. I've sort of categorized them. So if they're a leaner but still have insulin resistance, we want to go a little bit higher fat and protein, a little bit lower carb, but making sure we have caloric sufficiency here. If they're a little bit more overweight and they have insulin resistance, we want to do a little bit higher fat, moderate protein, and low carb with caloric restriction. I wrote here that calorie tracking can be really helpful. And I know that it can be a polarizing topic because there's so many of us that were, born in the 90s and doing calorie tracking in the early 2000s. And it was not so fun for us. But when I introduce patients to calorie tracking and it's sufficient calories, they're actually amazed at how much they can eat and how much food they actually need to fuel their body properly. So that's really important, especially for the lean individuals, because if we say you just go low carb because you have insulin resistance, then they're going to inevitably lose weight because they're probably not going to be eating enough calories. So it's really important. In the middle, we see where the commonalities of both of these dietary suggestions should lie, which is high fiber still, high polyphenol rich diet, anti-inflammatory, and low glycemic diet. So high fiber, we're looking closer to the 30 to 35 grams or more per day to stimulate GLP-1 and peptide YY, and to promote satiety and reduce insulin resistance. Polyphenols we can obtain particularly with around 5 servings of fruits and vegetables per day. We know that the research of 2 grams per day is really great for gut microbiome fuel. So in those low microbiome, low diversity states, 2 grams of polyphenols per day is great. I'm going to kind of glaze over this because it's very easy to read or research. You're probably very familiar with anti-inflammatory, low glycemic approach, replacing white sugars with more whole grains, and looking at avoidance of added sugars, processed foods, and having at least half a plate full of those non-starchy carbohydrates. And when we consume them first, that has a better insulin response. So by now, everybody has learned the top questions to ask their PCOS client in an intake, the 6 root causes of PCOS, what labs to look at, and at a high level, how to interpret. the best supplements to integrate to fulfill the client's goals and help them with their unique root causes, and fulfilling key nutrient gaps through an anti-inflammatory low glycemic diet. I'm going to open it up now to some questions, and forgive me, I think we've gone over a little bit. So if you are okay to stay, I would love for you to stay, and we will answer some of those questions. I'm just going to open up the chat if I can figure out how. There we go.
Yeah, thank you so much, Samantha. That was absolutely wonderful. And yeah, any questions that
Thank
anyone
you.
has, feel free, put them here in the chat, put them in the Q&A. I know Samantha mentioned it, but the course is beginning on March the 24th, which is a Tuesday. So it's happening in the evenings, Tuesday evenings, for 8 sessions. And so I'll also put a link here in the chat where you can read more information about the course and register for it there as see more details of what each individual session contains. And yeah, for now, we'll go with the questions.
Question here. Okay, what is the difference between PCOS and PCOD? I'm not sure what the D is. If you could clarify, I can potentially help you. And then how long can treatment take to resolve PCOS? Such a good question. So it really kind of depends on, of course, client compliance. I would say that dietary things are often the trickiest for people to grasp and get a hold of. So coaching them through that is a really foundational component. If a person is having irregular menstruation, we can correct the cycle regularity, I would say within about 3 months. But more longer term to work on really fulfilling the nutrient gaps. If they need to go through a gut protocol, kind of think around the 3 months to a year mark, depending on where they're at and what root causes um, there are. If I have low progesterone, does that mean I have PCOS? Not necessarily. Low progesterone can be a result of a variety of things. Again, looking at egg quality, looking at age as a factor, looking at some of the nutrients involved in progesterone production, things like vitamin C, overall a calorically sufficient diet. Testing progesterone, I would do like serum 7 days post ovulation. I generally look for it to be over 35 to 40. I believe that's nanomoles per liter. So if you're within that range, it's likely that that somebody is okay. But low progesterone can be, yeah, it can be a result of other things other than PCOS. PCOS can contribute, but not always. How much inositol do you recommend? Research shows 4 grams per day of inositol has the best effectiveness for improving inositol, not an inositol deficiency per se, but improving the cardiometabolic effects and insulin resistance and cycle regularity. Can inositol, berberine, and NAT continue to be taken by a PCOS client beyond 4 weeks once a positive test is achieved? I'm assuming you mean a positive pregnancy test. Berberine is contraindicated in pregnancy. Polycystic ovarian disease, different mechanisms there. So less of a insulin resistance metabolic effect, less of a hormonal concern there. PCOS is the syndrome. So we have more wiggle room and opportunities to use these natural interventions to regulate a cycle with PCOS. What do you think is the best way to treat hirsutism? I had PCOS and had a radical hysterectomy as I had endo as well. They told me to do laser surgery, but I read somewhere that oregano oil and black seed oil helps, and wild yam to treat hirsutism. To treat hirsutism, it's one of the trickiest symptoms of PCOS to treat. So looking at the hormone levels is important. If it is the testosterones that are high, then correcting those testosterones, either by virtue of like some of the things that we saw in the Dutch. So like saw palmetto can be helpful for hirsutism, reishi, spearmint tea is actually really great for hirsutism. And then addressing the root of why it's there is really important. Do clients generally need to gain weight, or can they simply increase fiber and supplements without weight gain to reverse PCOS? Oh, do lean clients generally need to gain weight? No, they don't necessarily need to gain weight. The goal of making it calorically sufficient is to ensure that they're not losing weight that they don't necessarily have to lose, and just making sure that they're getting enough calories with the appropriate um, macronutrient makeup. So a lean client with a lot of carbohydrates in their diet, insufficient protein, insufficient fiber, that might show up still as insulin resistance. Whereas when we correct those macronutrients, but still eating within a caloric sufficiency, that can help. Is there a correlation between having PCOS and developing rheumatoid arthritis? To my knowledge, there is not a correlation. Um, we might get curious around what are some of the things about having PCOS and that person's lifestyle that can overlap a diagnosis of rheumatoid arthritis. So, looking at gut microbiome function, intestinal impermeability, and how that can sometimes contribute to, inflammation and driving the immune system, and ultimately an autoimmune response. Um, if we think about how PCOS is often comorbid with Hashimoto's is an autoimmune disease. Oftentimes, when there's one, if it goes untreated, others can manifest. I thought you were also going to talk about endometriosis. Not today. Today's talk was all about PCOS, but we will definitely cover endometriosis in the course. Thank you so much for all of your questions. Are there any other questions before we will pass it to Theodore? You can conclude.
I think there are a few more here.
Oh,
Let me see. Although
maybe
I
they're
think
just
some
to
some
Theodore.
of them are duplicates though. So I don't think we covered this one. Let's see. If someone wants to take magnesium citrate and is already chronically dehydrated and might have some kidney and heart issues, is there a safer yet gentler and still effective magnesium citrate that one can take as it helps with lots of things considering PCOS and insulin resistance and etc.?
That's a very niche question. I would say it would probably be best to direct that to your naturopath or to a physician who knows your health history. Um, yeah, we'll leave it at that.
Yeah, I think it's great to know also that the course that we're talking about, that Samantha is going to be talking, because Samantha has, a wealth of knowledge, and today, like we said, there's so many different people joining today, right? So she's really catered the information to make it as accessible as possible for all of you. I think she did a fantastic job. And then in
Thank
the
you.
course, that's when she'll go into much more detail into all these kind of different specific situations, because as we know as practitioners, there's so many things that we need to take into account, right? And so that's why,
Yeah.
even some of the other questions, I know she gave some different, the recommendations and stuff, which are wonderful, but that's just touching the surface of everything that she'll cover there. But yeah, thank you so much, Samantha. It was absolutely wonderful to have you on today and to have you speak to all of us about this topic. I know it was very eye opening, even for myself, because it's not something I think about too much personally.
Yeah.
And
Wonderful.
once again, here, I'll put it in the chat again for anyone. This is the link to our website where, again, you can see the breakdown of the sessions and what will be involved in the throughout the course. And then there's a link on that page as well that you can click on if you want to speak with someone at IHN more about what is involved in the course, and of course to register for it as well. Wonderful.
Thank you so much, everybody, for coming. Thank you so much, Theodore, for hosting me today.
My pleasure, Samantha. Thank you very much, everyone, and hope you have a fantastic rest of the day and evening.